Hello and welcome to the program. I'm your host, Neil Howard, here on Health Professional Radio. Thank you so much for joining us. Our guest is Dr. Michael Edward Thays, professor of psychiatry at the University of Pennsylvania, and I'll let him briefly give us a little bit of background about himself and tell us about the patients that he normally sees. Welcome to the program, Dr. Thays. How are you?
Oh, thanks, Neil. I'm fine, and thanks for inviting me to be here with you. Well, in addition, as a professor, I teach medical students and residents, the future psychiatrists, as well as take care of some patients and conduct research. And so the patients that I see primarily are people with more difficult to treat depression and people with bipolar disorder who also often suffer from difficult to treat forms of depression.
Now, today we're going to talk about a form of depression called MDD, or major depressive disorder. What is MDD?
Well, I think if you grew up hearing other people talk and they said something like a clinical depression or a significant depression, that's what the term MDD really reflects. The major here simply means that the person's had a number of signs and symptoms of depression over at least a several-week period. But in truth, in the real world, most people who are suffering from a clinically significant depression have been suffering from a number of months, not for a number of weeks.
So is this something that's extremely prevalent, or is this a rare condition, generally speaking, when it comes to depression?
Well, it's gotten more common as the years have gone on, and so it used to be about 3% of people were suffering from a depression at any given time, but now it's recognized to be a number closer to 7%. And if you look across a lifetime, maybe 1 in 10 men and 1 in 5 women, or 1 in 6 women will have suffered at least one of these episodes of depression.
Is the method by which you determine whether a person is depressed or majorly depressed, has that changed over the years along with technology and the things that are going on in the world?
The basic definition hasn't changed much since 1980, so we're using for nearly 40 years now a very similar definition about the number of symptoms and the duration of time. What has changed is the ability to recognize when a depression's happening, which can be done online, and there are a variety of kind of self-rating scales that can help a person have a pretty good idea whether their level of depression is at this major level or not. And likewise, in primary care doctors' offices, screening has now become a standard of care, and you can screen simply with 2 questions with reasonable accuracy, and therefore, if you answer positive on those 2 questions, it's likely that you're in an episode of depression, and your doctor or nurse practitioner or other care provider can then do a more detailed screening to see if this indeed is something that warrants treatment.
Well, it sounds relatively simple to self-diagnose, and I know that that's something that isn't generally advised by healthcare professionals. But if it's something that can be diagnosed as simply as being online, what would you say are some of the biggest challenges that you face when it comes to some of these diagnostic tools?
Well, so at any given time, only about half the people who have a depression are actually in treatment, and so the number one challenge would be to identify a treatment that sounds interesting or sounds consistent with your understanding of how you came to be depressed, whether that's medication or whether it's a focused therapy or counseling or some alternative approach, and get going in that treatment with a qualified health professional or coach. And then keeping track of your progress and making timely changes in that treatment if the treatment's not working. Because depression's a state in which a more passive and not as active in terms of initiating actions and taking charge of things. Depression kind of saps you of some of your ability to do that. It's much more common for people to think, well, I'm going to wait a while or not even try to think about it at all. And weeks can turn into months, and sometimes months can turn into years.
Being such a complicated disorder, do people normally respond initially when they're first diagnosed to the first round of medications, or is there a waiting period or a hit and miss kind of wait and see thing to see what they actually are going to respond to?
The antidepressant medicines have pretty much two kinds of ingredients of benefit, and one is the so-called placebo expectancy effect. And that's the non-specific part of treatment. That's the probability of getting better simply from engaging in a helpful action and working with your healthcare provider to kind of get out of it. And this is a good thing. People sometimes think about placebo response as being like tricked or duped, but a person's ability to use the process of treatment as the vehicle to get better. Then there are the specific actions of the antidepressant, through which the chemicals that the medication works. And there are several different chemicals that are targeted: serotonin, norepinephrine, occasionally dopamine, and these are involved in the brain's stress response system. And the way that antidepressants work specifically requires some number of weeks. So typically, you need to be on the medicine 2, 3, 4 weeks until you can see a significant improvement, and maybe even as many as 8 weeks to see the full effect of whether that medicine is going to work for you. Now, if that medicine doesn't work for you, and it doesn't work 40 or 50% of the time, your healthcare provider can learn from that and pick a different kind of medicine. Now, all along, people might pick counseling or psychotherapy as an alternative to medication, and there's good evidence for mild to moderate depression, the kind of depression that most people suffer, that a well-conducted, focused form of counseling or therapy has about the same chance of working over 8 to 12 weeks that an antidepressant medication does over 6 to 8 weeks.
Would you say that you've seen an increase in this type of diagnosis in the younger population in the past few years, or is it something that mainly stays in the adult population?
Well, no, we've had a couple sweeping changes happen in our society over the past 30 or 40 years, and those sweeping changes have led to an earlier age of onset of depression, and so what used to be the first episode might happen around age 30. Now the first episode often happens in teenage years. And then the other thing that's just happened in the last 15 or so years is the risk of suicide in the United States has gone up pretty dramatically, whereas it had been stable the 30 years before that. And so not only are younger people more likely to develop a depression, they're also now more likely to attempt or commit suicide. And of course, we view suicide as a potentially preventable death because most episodes of depression are treatable.
Are you involved in any research right now, further research that looks into major depressive disorder?
Oh, sure. That's part of my life's work. And so we're always looking at different kinds of research. One kind is to try to facilitate and make better the treatments that we have. And then another kind of research is trying to develop and prove and test whether novel or new treatments might help improve the outcome of people who aren't helped by the current treatments. And so these studies kind of go along on parallel tracks, studies to refine the current treatments and studies to test the newer treatments. And so you may have heard among the newer treatments that are being evaluated, there's now growing evidence that other mechanisms of action, not related directly to norepinephrine or serotonin, may have different kinds of antidepressant effects, and that may be very relevant for people who aren't helped by the current treatment. So, for example, an anesthetic medicine, a medicine used as an anesthesia named ketamine, has been discovered in sub-anesthetic doses, only about a quarter of the dose that's used as an anesthesia, can have a very rapid and powerful, albeit short-lived, antidepressant effect. And likewise, another approach that we've worked on is a combination of medications that modulate the internal or the endogenous opiate system. And you probably know that human beings have used opium to modify their mood for centuries.
Absolutely.
But of course, the addictive and habit-forming qualities of that are part of a national epidemic right now with opiate medications. But this particular medication that we're working with is actually a combination of agonist and antagonist medications that minimize the habit forming or the addictive properties, but still retain some of the mood altering properties. And so there may be people who aren't helped by the conventional medicines who can have a fairly substantial response to these alternate treatments.
Where can our listeners go and learn some more about MDD?
I think there are all sorts of, if you just simply type major depressive disorder in Google, and I would start with the websites that are affiliated with the National Institute of Mental Health and the National Network of Depression Centers and the Depression Bipolar Support Alliance. Many of the pharmaceutical companies also sponsor websites that if you don't want to go into the advertisements for their medication, you can still learn more about the disorder itself. I think the American Psychological Association and the Academy of Cognitive Therapy also have some publicly accessible information on their websites.
Well, I thank you for joining us today and sharing this information.
Well, thanks, Neil.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Transcripts and audio of the show are available at hpr.fm and healthprofessionalradio.com.au.